Hello and welcome to the fourth livestream event of Raw Talk Podcast's COVID Decoded series. My name is Nathan, and I'm your host for today's discussion on public health and policy. Before we begin, we acknowledge this land on which the University of Toronto operates. It has been the site of human activity for the last 15,000 years. This land is the territory of the Huron-Wendat and Petun First Nations, the Seneca, and most recently the Mississaugas of the Credit River. The territory was the subject of the Dish with One Spoon Wampum Belt Covenant, an agreement between the Iroquois Confederacy and Confederacy of the Ojibwe, and allied nations to peaceably share and care for the resources around the Great Lakes. Today, the meeting place of Tikaranto is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to continue to work in the community on this territory. Here at Raw Talk, we're excited to share the stories about science and the people that make it happen. Check out our website linked in the description box below for access to all of our episodes, and don't forget to subscribe on your preferred podcast platform. Also, shout out to our intrepid team who managed to put together this live stream in a series in the midst of a literal pandemic. Alex, Kat, Jesse, Yagnesh, Richie, Thamia, none of this would have been possible without your support and dedication. Thank you. Today's COVID Decoded discussion examines public health and policy responses to COVID-19. We'll look at how Canada and Ontario have handled the public health response to COVID-19 to date, dig into public health interventions like mandatory mask policies, mass testing, and contact tracing, before coming back to explore the future of the COVID-19 public health response. Joining us are two experts in public health, Dr. Jeff Kwong and Professor Vivek Goel. Dr. Kwong is an epidemiologist, a specialist in public health and preventative medicine, and a family physician. He is the program leader of the Populations and Public Health Program at ICES, formerly the Institute for Clinical Evaluative Sciences, a scientist at the Public Health Ontario, a professor at the University of Toronto, and the Interim Director of the University of Toronto's Centre for Vaccine Preventable Diseases. He has conducted a range of studies related to the epidemiology of influenza and other vaccine preventable diseases. Professor Goel is a member of the Federal COVID-19 Immunity Task Force and the Governing Council for CAN-COVID, the national research platform for COVID-19 research. He is also special advisor to the president and provost of the University of Toronto and a professor in the Institute of Health Policy Management and Evaluation at the Dalla Lana School of Public Health. He was the university's vice provost faculty and was subsequently made vice president and provost from 2004 to 2008. He is also a founding and an adjunct senior scientist at ICES, and from 2008 to 2014, he served as founding president and CEO of Public Health Ontario. He returned to the university as vice president, research and innovation and strategic initiatives from 2015 to 2020, and he's just finished up with that job. As we continue forward with this discussion, be sure to submit your questions to our experts online in the YouTube chat box on your right, and as with prior episodes, we'll be ending the hour with a live Q&A session. Without further ado, welcome Dr. Kwong and Professor Goel. All right. So, our first question to our guests here today is, I kind of noticed that Dr. Goel here signed an open letter along with several other former civil servants and deans of medical faculties across Canada. And the letter, it's titled Dealing with COVID-19, A Balanced Response, advocates for changing the way that we're handling COVID-19 in Canada. So we're very fortunate to have Dr. Goel, one of the co-signers of this letter, here with us today. But before we kind of get into the specifics of the letter, Dr. Kwong, Jeff, can you talk about how public health agencies in Canada and Ontario are presently handling COVID? What have they kind of been doing about COVID to date?
Well, they've been very, very busy. Let's just start by saying that. At the provincial level, first and foremost, they've been ramping up the lab testing capacity so that we can identify all the cases of COVID who are out there in the community. At the local level, they've been very busy with what we call case management and contact tracing. And so ensuring isolation of those cases, the contacts, and the cases who've been identified. And at all levels, local, provincial, and federal, they've been busy doing surveillance and mathematical modeling to track where the outbreaks are happening and what interventions are required. They've also been doing research studies and knowledge synthesis to provide guidance and recommendations to government, healthcare system partners, the public, and other stakeholders. So all of these things have led to where we are now, where we have, with the current lockdown that we're trying to get out of, shutting down the schools and businesses, canceling large events, and keeping our international borders closed.
So it's clear that public health is doing a lot of different things right now. You're doing testing, you're looking at epidemiology, you're doing the modeling for all these local areas, a lot of different kind of facets. And on top of all this, of course, the public health recommendations themselves, as you're alluding to, the mask policies, etc. Okay, so we kind of have a sense that, public health has been doing a lot of this work, but Dr. Goel, Vivek, can you talk about what aspects of our current response motivated you and your co-signers to write the letter advocating for change in the way that we're managing COVID?
So, first of all, I just want to echo Jeff's points about how hard public health and our entire healthcare system and broader society, and I think really acknowledge the tremendous sacrifice the Canadians have made, right, over the last 4 months. And if you think of the number of people that are unemployed as a result of what we've done, everyone has worked really hard, and all Canadians have made a contribution to this. I also want to say our response to date is actually really good, despite what we might read about in the media and so on. If you think of our early response in January and February, Canada was a model globally for how to deal with a new virus like this, and the early cases were quickly identified. Contact tracing, as Jeff noted, was done, and we were able to work towards what should have been the appropriate way of handling something like this, a containment strategy globally. Our pandemic plans, and I was involved in working on a number of plans, as Jeff has been over the years, never anticipated failure south of the border.
Really?
They never anticipated the CDC not being able to roll out the testing program for the United States. They never anticipated EU countries like Italy and Spain failing at containment. And the situation that we wound up in at the beginning of March was not the result of what happened in China. It was not the result of what happened in Canada in those early months or any failures on the part of Canadian public health or provincial or local public health. It was a result of what happened in EU countries and the United States south of the border. And, I think we have to keep that in mind when we think about the situation that we're in, and I'll come back to this, and how we compare to some other countries in the world. And so I just want to start by saying the letter was not meant to be critical of public health. It was signed by many current and former leaders in public health. And all of the public health colleagues that have certainly responded to me have noted they agree with everything that's in that letter, right? And so I think it's important to understand the target for our letter was our political decision makers, the media, and the public.
Yes.
Because what we see that the conversation that we're now having about COVID-19 has become one of almost complete focus on COVID-19, preventing every case, containing every case, and it's starting to come at the detriment of the broader determinants of health. And I know we'll get into this a little bit later. When we talk about a balanced response, it's about balancing the consequences of the public health measures, which have now gone on for some time. Again, in the pandemic plans, they're never anticipated to be long-term measures that you keep in place until you develop a vaccine as your way out. And again, we can talk about how long it will realistically take to get to a vaccine and get it deployed. But if we're going to stay in sort of the current mode, even what we're talking about as phase 3 reopening, it is going to mean that we will have severe population health consequences as a result of those measures while we try to continue to limit the number of COVID cases. So when we talk about balance, it's looking at a balancing of all those health consequences. I'll just maybe close. Many people have framed this as economy versus health, and I certainly think that's a way to think about it. But the writers of that letter are not coming at this from an economy versus health perspective. We're purely coming at it from a population health and equity perspective.
Absolutely. I want to actually dig into this just a little bit more. So, would it be fair to say that this letter would not have been published then had Europe and the US and other Western countries essentially successfully mounted a containment response, like Canada?
Well, so let me, I can't say if the letter would have been published or not, but if we hadn't had, in particular, the failures of control in New York City, if you look, and Jeff is probably more familiar with this, but if you look at the viral strains that are circulating and so on, the dominant strains now in Canada for some time have been the European strains, not the original strains that came out of China. And so if we hadn't, if we had stayed on track with the original pandemic plans, I don't think we would have had the widespread community transmission that we've seen, and that's what came into Canada from Europe into Quebec, returning travelers from Europe after the spring break there, and into the Toronto region, Ontario, probably people coming in from New York, from Florida, as the travelers returned. We had a few imported cases from Iran into BC. Like you look at where it came in, it was a result of that. And I think it's fair to say people were perhaps caught off guard on how fast it moved through those jurisdictions. And we got to community transmission very quickly in Canada as a result. It also speaks to, if you go back to February and March, when everyone was calling for closures of the border with China, I had an op-ed which pointed out, as many other people did, that closing borders is not a appropriate response mechanism. And we could have closed our borders with China. It still would not have stopped where the virus ultimately came into Canada from.
Mm-hmm. So that's really interesting. Basically, it looks like kind of the way that we're going to talk about the future at the end of this discussion, but looking forward, it looks like our response to COVID is directly shaped then by the way that others kind of have responded to COVID. And so that the fact that you're advocating for a change in our response is not a criticism of our public health response, but rather identifying that our public health response is not independent of other responses in other jurisdictions, and we must accommodate for them, especially given that the U.S. is literally our largest neighbor and biggest neighbor and 10 times our population, and kind of is a different situation there than here.
Yeah, and if I could just make one other point, and I think Jeff might want to add on this as well, is we often have comparisons made with Iceland and New Zealand, and there are countries that have achieved close to containment and managed to get their community transmission right down very close to zero. They tend to be smaller. They didn't have, I think, ever the level of community transmission that we got to back in March and early April. And they don't have the United States sitting next to them. And, and we can talk about the border being closed. It's closed to non-essential travel, but we can't close the border with the United States. We would starve to death, quite literally, right? And so we are in a very different situation than the other countries that often get held up as examples. And so again, when we think about what our response is and what the appropriate response is, absolutely right. The virus does not respect the border, right?
Absolutely.
And it's going to come in regardless. And especially when we have this longest undefended border to the south of us with a country that is failing in its response, it does change the situation for us.
Absolutely. I want to touch on something that you kind of mentioned or alluded to earlier too, which was essentially that the public health response to COVID-19 needs to be balanced against some of the more negative effects, especially that of the measures themselves directly and COVID itself directly. And so to that end, I'm quoting here from your letter now, the consequences of the public health measures due to COVID-19 have not been shared equally in society. Those in lower income groups, Black and other racialized groups, recent immigrants, and Indigenous people are bearing disproportionate burden. So Dr. Kwong, I know that some of your research at ICES echoed some of these findings earlier on, way back in late April, early May, you were saying how patients or individuals who got tested for COVID-19 had a tendency to come from lower income neighborhoods or neighborhoods with more immigrants and visible minorities. Can you, I guess, talk about how COVID-19 has been, what this disproportionate impact of COVID-19 actually looks like towards marginalized populations?
Yeah, I think it boils down to two factors. I think it boils down to workplaces and housing. Think of where do we spend most of our time, either at work or at home? And so I think it's not as much about visible minority groups and immigrants as much as where people are working and where people are living, and that these workplaces may be unsafe for them. So if you're able to work from home, then that's a much safer environment. But if you have to go out to work and you're potentially exposed to the virus, so a lot of the people who had to continue working through through this pandemic, were at risk of exposure. And a lot of these people were visible minorities and immigrants. They're at jobs such as like personal support workers at nursing homes, or they worked in food processing facilities. So these are just like some examples where they might be working in close contact with others. They either don't have access to personal protective equipment, or they don't have training on how to use it. And then they're going home where there may be crowded living conditions. So there may be many people living in an apartment or in a house, multi-generational families, where it would be hard to maintain physical distancing with others. And so then they introduce the virus into their household, and it spreads to the household. And maybe one of the other people in that household also has to go to work, and then they bring it to their workplace, and then so on and so forth. This is how we were seeing it spread in March and April and May. Mm-hmm. And hopefully, now a lot of the workplaces have instituted a lot of measures to protect their employees. And hopefully we can also have more measures to protect people, who live in crowded housing. So there has been talk about, allowing people who live in crowded housing to have, to stay in alternative places like hotels, so that they can properly self-isolate. So I know that there has been talk at both the local and provincial levels of having programs like this in place to help people, to support people to self-isolate.
So I guess kind of what I'm getting from this then is it's two things. One, the feasibility of your ability to comply essentially with a social or public health measure seems to be one of the most important factors to whether or not you'll end up getting COVID or be impacted by COVID. Feasibility is a key component. The other half of this kind of sounds like a lot of these issues were present even before COVID kind of came about. It's not as though racialized or marginalized communities suddenly decided to live together having heard about COVID-19. That seems kind of absurd, right? So it's, it looks like the existing situation has contributed a lot then to how COVID has impacted marginalized populations.
Yeah, that's right. I mean, the other factor is like, maybe they have trouble because of language barriers or unfamiliar with the health system. They may not be aware of how to access testing, or maybe being able to advocate for themselves to get tested and to access other health services. So all of these things may be playing out. They're all these social determinants of health kind of are converging. It could be lack of education, and then they have a low-paying employment, and then they're working in unsafe conditions and not able to advocate for themselves, and all of these things are coming together.
All right, yeah. Well, it sounds like obviously then the impact of COVID on marginalized populations is it's not straightforward as simply marginalized populations were always more susceptible. It's that there's all these additional factors that contribute to to the lives and lived experiences of marginalized populations. And then when you kind of play that out, that is ultimately how that's how COVID's impact is manifesting. And I really like that. What I'm going to say is we'll come back to this idea of marginalized populations towards the end of our discussion and what we can kind of do about this in terms of public health and COVID. But as we're kind of before we kind of switch over to the next section, heads up to our audience that if you have a question about what you want to see with respect to changes moving forward with the public health response, or how we might address some of these issues, or questions even about what's already happened with the public health response, please go right ahead and drop us a question online on YouTube for our live Q&A at the end of the hour. So,
can I just
yeah,
sorry? Can I just add in a point on this? So, I agree with all the points that Jeff has made. And
yes.
First of all, just there's been a lot of speculation about, you use the word susceptibility, that are some of these populations somehow more susceptible. There may be some genetic factors. There's lots of research to be done on that. There may be some basis for some of the pre-existing conditions that lead to higher risk in certain populations. But I really want to emphasize Jeff's point. This is actually not about biological predisposition in some of these populations. It is the nature of the social determinants of health, which, as you said, we've known about for a long time, and COVID really makes transparent. But I do also, because you read out the quote, we were talking about the consequences of the public health measures as well as the consequences of COVID-19.
Yes.
And when you think about, and Jeff said this at the start, the people that could take the public health measures, work from home, are people like the ones likely on this call.
Yeah.
And we've got the technology. Our jobs allow us to continue to do. Even family physicians were able to move to virtual care, which is like 30 years of progress in a month.
Yeah.
But the people that Jeff described, if you're working in a grocery store or as a personal support worker in long-term care, your work, you can't take those public health measures. You have to continue to work, and that enables the rest of us to keep working. But if we think about the places that have been affected as the economy got shut down, again, if you're able to work from home, continue to make your income. If you're not able to work from home, you eventually got laid off. And Canada has been exemplary in the programs it created, like the CERB, that provided support for those people. But as we come back, if we look at what's going to happen in the restaurant and the retail industry, there's been a wave of closures already of stores being announced. And restaurants, right now they've got patios. They're going to operate on probably 30% or less capacity with 2-meter separation going forward. The people that will lose their jobs will wind up being the very same people that Jeff described, because those are the people working in the service sectors. The hotel and tourism industry, with borders closed, globally accounts for about 10% of the jobs worldwide are related to travel and tourism. So as long as those sectors stay shut down, there are also going to be consequences from the public health measures. And again, in writing that letter and thinking about balanced response, what we're saying is we have to also think about those consequences.
Sounds like often, I guess, in public health, you're caught in a catch-22. You do one thing and it'll kind of make one problem better, but it'll raise the specter of the second problem right after. So it's a hard job, and I can imagine that. And with that said, I think what we'll do is we're going to quickly move over to our next section on public health interventions before we kind of come back to this topic again, just to when we will more in-depth discuss the future of Canada and Ontario's public health response. So with that said, public health interventions, these are a huge range of all of the different measures that public health agencies introduce to kind of combat diseases and other issues within the population. And I want to focus on a particular intervention implemented due to COVID, that is to say, mandatory mask usage. So this policy, the idea that you have to wear a mask mandatorily indoors, was introduced in Toronto, I believe, last week. And these types of policies are showing up all over the place in jurisdictions in Canada and the US and more broadly in Europe and elsewhere. They are also very much present earlier on in Asia as well. I'm kind of wondering, Dr. Kwong, if you can take us through some of the guidance on mask usage. How has that kind of changed in time? Because I know that at one point, we were not all saying let's wear masks. And what has motivated this change now towards mandatory mask policies?
Yeah, I mean, at the start, we were telling people, only wear only if you're sick do you need to wear a mask, or if you're caring for someone who's sick, do you need to wear a mask? And that was when we thought, oh, you only are, contagious or infectious when you have symptoms. And then we started realizing that people may be infectious before they have symptoms, and then there's some people who may have no symptoms who could be infectious as well. And when we realized that, and we also just, observationally, like anecdotally, we saw in other countries where, they had a lot of mask wearing and they seemed to be able to get control of the infection. Then we started realizing that maybe we should be encouraging greater use of masks. Then there was the issue of like, are there enough masks for people to use? And, there was already a short supply of the, N95 respirators, as well as the surgical masks for the healthcare system and for our healthcare workers. So we didn't want the public buying up all the supply of these masks. And so, that was another factor that went into the decision not to recommend masks early on. And then later on, we realized that, cloth masks or, homemade masks might do enough for what we call source control. So people who may be unknowingly infected, if they wear a mask, a non-medical mask, that's good enough to capture the droplets that are coming out of their mouths when they breathe and talk. And that can, do the trick of preventing, spread of that infection from that one person to others. And so the idea is that, we need as many people as possible to wear masks for this strategy to work. There may be some protection for the person wearing the mask from others, but mainly it's source control. And so, we are also learning that, a lot of the transmission is happening indoors when there's like poor circulation. The virus may actually be hanging around in the air and that sort of thing. So, outdoors, we weren't seeing as much transmission. We think that the air currents are blowing the virus away. And indoors, where there's good air circulation, we weren't seeing a lot of transmission. So that's how we came to where we are now, where we're saying, if you're going to an indoor setting, then it's mandatory to wear a mask, because we just don't know who's infected, who's not infected. You may be pre-symptomatic or asymptomatic, and you could be shedding virus. You could be spreading to others, through your talking and breathing. So that's why, we're at where we're saying, it's mandatory in Toronto and in a number of other jurisdictions. Quebec just made an announcement recently that's saying that it's required, throughout the province for indoor spaces, you have to wear a mask. So, I think this is, a good thing. I think it's good that we have, I think there's a lot of, I think our society thinks very collectively, and there hasn't been as much resistance to this recommendation and in some places requirements as there has been in the U.S. And I think this is going to, help to protect all of us.
Definitely. I know that mask policy was also something that Dr. Goel, Vivek, the letter also addressed to. And I think in the letter, it's talking a little bit about how we want to make sure that masks are or any mask policy is logically linked to the goal that it's trying to achieve. So I guess, Vivek, if you can talk about some of the goals of mask policies, what is the actual, what are they actually intended to kind of limit this transmission? Is this what it'll do?
Yeah, so I think, and to just build on Jeff's point, and again, I agree with everything he said, is that we have to be able to communicate clearly to the public what the purpose of wearing the masks is, and the distinction between personal protection, which is important for healthcare workers or grocery store workers who are getting potentially exposed to people who may be either symptomatic and infectious, or asymptomatic or pre-symptomatic and infectious, versus the source control to delay community or stop community transmission. And I think there's a lot of confusion in the public about what the purposes are at times as well. And I think in terms of the mandatory mask policies that are being introduced, I would add in, they are really being focused on public places with high circulation where there's large amounts of mixing. So retail, and those types of public lobbies and so on. And it's about where contact tracing after the fact, I know we're going to come to that next is more difficult, right? So if you have people mixing in a shopping center, it's an indoor space, physical distancing at 2 meters becomes more and more challenging, and you can't keep track of everyone. Adding in masks in an environment like that does appear to make a lot of sense. It's not, a lot of people are interpreting this as it's masks for all indoor spaces. If I'm sitting alone at my desk in my office, I don't need to wear a mask, right? And so again, that's where in our letter we're saying we really have to be clear around the risk profile in different environments and different settings, and otherwise people getting confused about where they should be. I see people riding their bike down the street with nobody around them wearing a mask, and you say, what's the purpose of that? And they haven't had clear communications and clear messaging, and so as a result, they're wearing masks probably in environments that they don't need to be wearing masks.
So I guess to summarize that, you're wearing a mask to prevent yourself from potentially spreading the disease to other people.
Yeah, and I think the distinction is really important because we talked about in the previous one, like making sure that people working in higher risk of infection environments have the appropriate protection. And so, depending on what the level of community transmission is, a worker in a retail outlet should actually be getting masks for protection. And in that case, Jeff, I would be saying that that person should have a medical grade mask, not a cloth mask, because as you said, it's not as good at protection. But we're seeing lots of people in those settings wearing cloth masks because of the confusion that's out there, versus the customer in the retail setting who's just going in for a few minutes should be wearing a cloth mask to avoid that asymptomatic transmission to others. But because of all the confusion, so that's what we were really saying in the letter, we have to just be more clear and crisp, and it has to be geared to the level of community transmission in a particular jurisdiction.
That's really interesting. Yeah, I'm not sure if that message is entirely clear yet, that, if you are working in a very public-facing job, constantly interacting with people, yes, to consider getting that medical mask. If you are not, then maybe consider cloth masks.
I'll just rephrase what you just said, because in that setting, if there is higher levels of community transmission and that worker is at risk, the employer has an obligation to provide appropriate personal protective equipment for that employee. It's not just up to that. And so again, it's not up to that employee to figure out, should I be wearing a cloth mask or a surgical mask?
Yes.
But to be honest, I don't think we're really giving clear guidance to all those employers. If you're running a little restaurant with 3 employees, how do you figure out all the guidance that's coming out at you?
Yeah. I'm reminded of like AODA compliance, Accessibility for Ontarians with Disabilities Act, and the compliance for that is really dependent on how many people are in your organization. And so they have different rules if you have at least 50 people in your organization, and I imagine that's probably for good reason. But yeah, especially when you're working with employers who are potentially employing less than 10 people, trying to find out some of this information for themselves is challenging if it's not clear. So I'm glad that we do have actually a clearer response here, that it is actually your employer's job to determine whether or not you're wearing a medical mask or a surgical mask, and that determination is generally based on a risk assessment that considers community transmission and how public-facing that job is. So, okay, I like that a lot. I guess on a similar note, I want to ask how we can connect the idea of compliance behind a public health intervention and the effectiveness of that policy itself. So, for example, like mandatory mask policies, where the intention here is to kind of limit the likelihood of an asymptomatic or pre-symptomatic individual from transmitting COVID. To what extent is that goal affected by the likelihood of everybody like 99% compliance with the mask policy versus, like 50% compliance or 10% compliance? Do we consider kind of pushing these policies still if we don't reasonably expect compliance to be very high? Is this kind of like a wasted effort, so to speak? I'm wondering if you can kind of speak to that. Jeff.
Yeah, I'll go first. I mean, no intervention are you going to achieve like 100% compliance, right? And so, I think you're happy if you get like 90-something%, obviously. But, I think the models are showing that, even if we have lower than that, we can still have a lot of benefit. So I think the message is that we need as many people to do this as possible, and this could really help to dramatically reduce transmission. But if there are some people who are not able to do it, I think it's similar to vaccines, right? Like there are some people who can't get vaccines for whatever reason. They'll be protected by if everyone else is getting vaccinated, and here, if everyone else is masking. So it's more of I think we need to frame it as a civic duty. I'm wearing a mask to help protect everyone else around me as much as possible. And if we all do it, then we're all, this is how we're all in it together.
And there seems to be a bit of a herd immunity analogy here, right? In terms of just if everybody's doing it, then, it's far less likely that any one individual is going to get infected.
Exactly.
Yeah.
And I'll just add in, first of all, we don't want to get into a enforcement environment where we have mask police running around issuing tickets to people for not wearing a mask. And first of all, going back to our earlier conversation, there was a very interesting report from the Canadian Civil Liberties Association a few weeks ago about who got all the bylaw tickets on physical distancing in April and May, and it tended to be the same communities that we were just talking about, yes, right? Yeah. And so, if we start to get into mass policing, I think it's going to be just like carding and other things. Police are going to be stopping people, and it's going to be very arbitrary. So, I don't think that's a society that we want to be working towards. So it's just, we should be encouraging a community sense that everyone is in it together. But the other thing that I think is really important is masks are an additional layer. If we can get to 70% or so on, it's going to help in the models reducing community transmission a little bit further. We have to keep reminding people that the most important things, staying home if you're symptomatic, continuing to practice frequent hand hygiene, those are the things that actually have the greatest impact. And then we're getting smaller and smaller marginal benefit with some of these other things. But when you get to really high levels of community transmission, those marginal benefits become quite powerful.
That's really interesting. I'm going to switch gears quickly now. We're going to talk about contact tracing. So I know that contact tracing was probably one of the earliest things that we kind of introduced to deal with COVID. What exactly is that process, Dr. Kwong?
Yeah, so this is one of the basic tools of public health. So in the context of COVID, what happens is first of all, a lab has to notify local public health that they've identified a case. Then the health unit in Ontario, the public health units, are the ones who are responsible for what we call case management and then contact tracing. So what they first do is they call the case, and then they advise them that they need to self-isolate, for a period of 14 days, since their symptom onset. Then they interview the case to identify who they've been in contact with, starting from the 48 hours prior to symptom onset until the start of their isolation period. So once they've assembled that list of contacts, they then have to contact all those people and let them know that they've been exposed to a case of COVID. Now they'll tell them to go get tested for COVID and that they have to go into quarantine, for 14 days from the date of their last exposure and to monitor for symptoms in that time. So that's the process of contact tracing. They do have public health has the legal authority to enforce, to mandate people to stay at home and isolate themselves or quarantine themselves for that period.
That's great. And I guess kind of before we move on a little bit more, Dr. Goel, if you want to talk a little bit about COVID Alert. This is the app that I think Ontario was developing and was supposed to be released earlier this month. We're not kind of sure where that is now. But I wonder if you can talk about COVID Alert.
Yeah, so maybe I'll just say a couple of words about the different kinds of apps that have been developed around the world and where COVID Alert fits in. So the simplest use of sort of a phone app to support contact tracing is to essentially help use it as a diary. And so as Jeff described, if you get a positive result, you get contacted by the contact tracer, you can use your phone's location history to provide where you've been to that contact tracer. And it can help them in facilitating the recall, and you just have to have location history in Google or whatever location apps you're using turned on. And there are apps that make that easier. You press a button and it texts all that information to the contact tracer who can then take that on. The second type of app uses GPS technology, and which actually tracks where you've been and pulls that in so that if you can match up where people have been using their location histories. Those types of apps create a lot of privacy issues, particularly in our kind of environment, but they have been deployed in some other countries. And so the COVID alert app that is being developed for Canada, and Ontario will be the first province to implement it, is based on this Google Apple API that they launched a few months ago. It's a unique example of these two giants sort of working together, and it's based on Bluetooth technology. And so when you come near another user of an app, and it doesn't have to be whether it's an iOS or Android device, the Bluetooth will engage in a handshake. It can be tuned to the amount of time that you're in contact, so it could be 5 or 15 minutes, so you don't just get sort of random contacts being recorded. A pair of encrypted keys get uploaded to a server. There's no location history. There's no time history other than keeping track of the day on which it came in. So then if one of those individuals is later confirmed as having a diagnosis, when they get in, the contact tracer from public health gets in touch with them, they can be provided with a special key that they go into the system, and it will then result in all the people for whom those handshakes were exchanged to get a notification. So they get a notification alert. All that person gets is sometime in the 14 days prior to this, you came within Bluetooth exchange of, I mean, that's not a word, but that's what it means, of someone who had COVID-19. You won't get any further information from that. And public health won't know anything more than that either. So it is of very limited value, but it ensures that the privacy, the location history of the individual is not infringed upon. There's a couple of weak links in there. First of all, people have to download and enable the app. Very much like our previous conversation, you have to get to a high enough level of coverage in the population. And the magic number keeps coming up as about 70%, because the models are also that you need to get at least 70% of the users in a country using the same app for it to really get to some level of effectiveness. And then the second weak link is that the person that gets tested positive has to go back and upload that key back into the system. Whereas with some of those other approaches, the GPS technologies and so on, public health has access to that information. And so out of this, there's not actually that much data that will get generated that will be of any meaningful value for public health. But I do think there is still importance in the app, because I think just the act of downloading it, when they start to roll it out, the Prime Minister, the premiers, ministers, so on, get people to ask them to download the app. We can put all sorts of other public health messaging around that. And so it's going to be a really good education opportunity. And similarly, when someone gets that exposure notification, not just do it in isolation that, hey, you were in Bluetooth contact with someone in the last 14 days. Here's what you can do to keep track of your symptoms. If you have symptoms, here's where you should go to get tested. And that can be based on their location and give them really personalized information about what they can do next. So what I see as a really great opportunity with the rollout of these apps is to wrap a lot of public health education around them.
That's great. Yeah. So it sounds like we're on the cusp of rolling out an app that is able to deal with our privacy considerations in a conscionable manner, yet at the same time, although maybe not providing public health with usable data, it does provide at least public health a tool for public education, which is fantastic. All right. I'm just being mindful of time here. We're going to wrap up in about 15 minutes. With that said, let's move on to our final discussion. We'll be quick, and then we'll move on to audience Q&A. So our final discussion here is just going to be reviewing kind of the future of Canada and Ontario's public health response. So in particular, what do our experts, Dr. Goel, Jeff, what do they think about how things are going to be changing moving forward? So with that said, I want to start first with our discussion about marginalized communities. So within marginalized communities, what are some of the specific actions that we can take to ameliorate some of the disproportionate burden caused by COVID or the public health measures introduced because of COVID itself? Jeff, if you want to start.
Yeah, I mean, I think we've been doing a lot of them already. So for instance, let's say for the homeless population, we've been putting them up in hotels so they're not crowded in shelters. And so like measures such as that, for the homeless and underhoused, and maybe even for people who are living in overly crowded situations when they have to be self-isolating. So it can be short-term, for the people who do have housing. It can be long-term for the people who don't have housing. So it's measures like that we are doing already. And I think that's really helped to control the spread in a lot of our settings. I mean, I think the fact that we've, got the number of cases each day, coming down dramatically, in the last couple of months, showing that, what we are doing has been effective. And I think we just have to continue doing those, but to continue supporting the most vulnerable members of our communities, the marginalized, and as we start reopening workplaces, these are the settings that we need to be extra careful about, where, not able to maintain physical distancing, and, hopefully the masks will help to mitigate that risk a bit.
Yes.
But I think, those are the main things. And, I'm not sure, Vivek, if you have other ideas of things that we should be doing. I mean, until we get a vaccine, I think we should, we need to continue doing these things, and hopefully we will have a vaccine, sometime within the next year or two. And then we can, at that point, have a conversation about who we should be prioritizing. Should it be, some of these marginalized, populations? Should it be just the people at highest risk of death? I think these are conversations that will need to happen.
Vivek?
Yeah, so I'll just add, so first of all, I think, and we need to be honest with the population about the vaccine. And I agree with you, it's 1 to 2 years, not Operation Warp Speed, and we'll have it by December, like Donald Trump is promising. And then as you also said, we have to be honest that it will take several more years to roll out a global campaign, because it's not just, we'll have to prioritize in Canada, but we'll have to prioritize around the world. And, we're going to be looking at getting at least 5 billion doses to people around the world to get to levels of herd immunity. We also don't know if a vaccine we'll have to do it annually, like flu or so on. So I think we have to be honest with people about how long it's going to take and what that's going to look like. And I think we also have to be ready for a fall wave and for continued sporadic outbreaks. We can't, I think really in terms of the letter we wrote, we can't just keep saying we're going to have to go back into another lockdown if we can't manage it. We have to be ready, and we know a lot more than we did back in March. We know about which kinds of communities Jeff has been going over, the outbreaks we're in, which kinds of work settings. Let's make sure that they're prepared so we don't have outbreaks in meatpacking plants and long-term care facilities, homeless shelters, agriculture workers. Like, we know the settings in which we've had the outbreaks, and so we should really be focusing on this. We know the people that are most likely to get hospitalized and die, and so we need to make sure we have the supports for those. But we also know that there's a lot of people who are at much lower risk, and so we have to be able to ensure that we can continue to manage to allow those people to work and go about their daily lives, so we can generate the resources that we're going to need to keep the rest of people protected.
Absolutely.
And so the key things, Jeff has referred to these, we need to have testing capacity, we need to have contact tracing capacity, as happened in Kingston a few weeks ago when they had the outbreak in the nail salon. As they come up, get them controlled really quickly. If we don't have that capacity in place, I do worry we will have to head towards another lockdown, and I don't know how we would get ourselves out of that. And the consequences will be very severe.
Yeah. So it sounds a lot like, essentially mass testing, contact tracing, almost the two basic tenets of public health by this point. Ultimately, if they're not at the top of their game, those who are impacted the most when these policies are not working effectively are essentially the marginalized populations. So, of course, we need to continue to support these and moving forward with them. I love that message. I'm going to switch us over to our last little bit with our live Q&A with our audience. So, with that said, I'm looking here. Got a question about the effectiveness of quarantine policies in the absence of American action. So this is interesting. So this question in front of us is, to what degree are Canadian quarantine policies affected by the US and other countries? Specifically, how effective can Canadian policies be if other countries do not have similar policies?
So the purpose of quarantine is to address travelers coming into a particular jurisdiction. So as long as we have strong quarantine programs in place, it doesn't really matter what is happening in the other jurisdictions. Where I think that questioner does have an important point, though, is people are talking about travel bubbles being created between different jurisdictions. And so as an example, if Canada and some Caribbean islands, I know a lot of people will probably be looking forward to a winter vacation next year, both have low transmission, and they create a bubble for people to go back and forth. But that island also opens itself up to the United States, and they still don't have things under control. Canadians will go there and bring it back. So the bubble will also have to have the same quarantine requirements. But I think the key issue is what will we have around our borders, and we will have to maintain those kinds of requirements with countries like the United States and Brazil, where there's widespread community transmission.
Jeff?
Yeah, I mean, I agree with Vivek, and I think I think it'll be critical, that we maintain this 14-day period of quarantine for incoming travelers as well as returning travelers, and I think I wonder if our current measures are adequate. Right now, it's kind of like, you're told that you have to do it, but the actual enforcement, may be limited. And, maybe we're getting away with it with the numbers that we're having right now. But as there are, more and more numbers, you always worry that there's just a few bad apples out there who choose not to abide by these orders. And, how can we, prevent that from happening from spreading it to others? And so that's what worries me as we start to reopen our borders, perhaps to other countries, or, as Canadians start traveling to other places, and when they come back, we don't want them bringing it back and then infecting either the household members or others in the community.
Oh, great. And I want to ask one more question from the audience as well. So this question is on the cost effectiveness of public health policies. We often use cost effectiveness analysis in public health. And are we using this type of cost effective analysis for COVID-19 decisions? If so, how do we quantify the costs of things like children missing school? I think what the question is trying to ask. Sorry.
Go ahead. Yeah.
I think what this question is trying to ask is essentially what is the cost effectiveness of COVID-19 decisions, and kind of that balance. It's alluding to the balancing that I think Vivek was talking about.
Yeah, and that is absolutely part of our message is I think in some of the current decision making, again, I would say it's not necessarily public health decision making, right? This is what the public is showing with their revealed preferences and surveys and what they are talking about with the politicians, and as a result, what we're seeing. So, yeah, the focus on children, I think, is absolutely essential. And the Sick Kids report from a few weeks, I think, highlighted very clearly the consequences for kids on their development of a long-term shutdown. Early childhood development is the strongest predictor of their lifelong health.
Yes.
And so if we keep them out of school, if we keep them out of the social interactions where they learn that will affect their development over lifelong. I don't think a cost effectiveness or a risk benefit analysis is actually being done because we have allowed ourselves to become so focused on averting every case of COVID-19. And that also enters into, I think, some of the other decisions that are being made. And that's exactly what, in the balanced response, we're saying we need that kind of analysis. I wouldn't actually use the term cost benefit. I would say risk benefit analysis. Cost is one of the things we could look at, but I think it's just from a health perspective, you can look at the risks and benefits.
And Jeff?
Yeah, I agree. I mean, I think the tricky thing with these is that, we don't really have a counterfactual. Like, we don't know what would have happened if we hadn't introduced these things. How many more cases would we have? We can kind of only conjecture what it would be like. We can cite Italy, we can cite New York City, we can cite right now what's going on in Florida and elsewhere. So we assume that if we had suddenly released all our lockdown measures, we would have a situation like that. But we don't know for sure that would be the case. But that's why it would be tricky doing these sorts of analyses.
Great, yeah. And I think that pretty much brings us to the end of our discussion. I want to ask you one final question. I know, we started this conversation right at the beginning, and I think the first thing you mentioned is public health is working really, really hard to deal with COVID-19, and I think we really appreciate that. I certainly do, as an individual. I guess my final question to both of you, do you have any words of advice or support for your colleagues who are currently managing the public health response in Canada and Ontario? Jeff?
Yeah, I mean, I think, you summed it up really well. All of our colleagues are working extremely hard. So I think it's important to recognize that this is truly a marathon. This is going to be going on for like months or years, and not like weeks for sure. And so it's important to take care of yourself, and do the things you need to do to stay healthy and to keep your mind sane, because this is going to be going on for quite a while. And so to pace ourselves and to support each other, I think those are the important things that everyone needs to do, especially those working in public health.
Mm-hmm. And Vivek?
Yeah, I agree with Jeff. Maybe I'll just have a word for your listeners, because I know many of you are students in different disciplines. Consider a career in public health. It's really exciting.
I can imagine. Yeah, this is probably, I imagine it's the busiest time that public health has ever been.
Yeah, but I'll also, maybe I'll just close by saying, public health is about more than infectious diseases. Mm-hmm. And if anything, what COVID-19 has shown, the broader social determinants of health, equity, the importance of chronic disease prevention and control, because it's people with chronic diseases that are at greater risk for COVID-19 consequences. And when there's not something like COVID-19, public health people are still working there really hard in the background, and nobody knows about them. And so there are really exciting things that happen in public health, even when there isn't a big outbreak or a pandemic like COVID-19.
Yeah, I'm reminded always of the analogy between public health and computer IT. In any organization, you only really think about IT when things go wrong, and inevitably when things go wrong, it turns out they've been underfunded.
Yeah.
Yeah. So, anyways, thank you so much, Dr. Kwong and Professor Goel, for sharing your time with us today. I have certainly learned a lot, and I am sure our audience has definitely learned a lot as well. To our audience, send your feedback about COVID Decoded through the survey link in the description box below on YouTube, and come back next Thursday, July 23rd at 3 p.m. for the 5th live stream event with Gideon Foreman and Shuk Odenigbo. Jesse Knight returns to host a discussion on the intersection of climate change, equity, and COVID-19. This series would not have been possible without the support of Pillar Affinity sponsors, TD Insurance, and MBNA. Thank you for helping make this series possible for our team. Check out the link in the description to learn about preferred insurance rates and credit card rewards for U of T alumni. Want even more Raw Talk content? Check out our past COVID Decoded streams here on YouTube, where we discuss topics like virology of SARS-CoV-2, epidemiology and modeling of COVID-19, and the psychological impact of COVID-19. Follow us on Instagram at Raw Talk Podcast, where we're sharing stories from folks on the front lines of the pandemic, within and beyond healthcare. If you know anyone that you'd like to nominate for this feature, please direct message us on Instagram or Twitter. Finally, support the show by using our Amazon affiliate link in the video description below. And thanks for tuning in. Until next time, keep it raw.